Liver fibrosis develops as a consequence of both inflammatory and non-inflammatory damage. In case of death of small groups of hepatocytes and preservation of reticulin framework, the liver can regenerate without any scar formation. More extensive damage with destruction of hepatocytes and collapse of reticulin fibers will initiate fibrosis. The key player in development of liver fibrosis is a hepatic stellate cell. These cells are able to transform into myofibroblasts and produce collagen. It leads to formation of pericellular and perisinusoidal fibrosis. This microscopic slide is stained by blue trichrome. Therefore, a fibrous tissue is highlighted in blue color. Pericellular and perisinusoidal fibrosis is apparent as a delicate meshwork resembling a chicken wire fence and surrounds individual hepatocytes or lines liver sinusoids. This process leads to obliteration of fenestrations in liver sinusoids and deterioration of nutrient and oxygen exchange between circulation and hepatocytes. As a result, the fibrosis aggravates and becomes more compact. Localization of fibrosis usually corresponds with where previous necrosis or inflammation occurred. Periportal fibrosis is thus typical for chronic hepatitis. Fibrous portal tracts are enlarged, irregular, and spiked. Central lobular fibrosis is characterized by fibrosis around terminal veins and is typical for alcoholic hepatopathy or right-sided chronic heart failure. As time passes, the fibrotic foci from individual zones of liver lobules start to merge and create fibrous septa. This stage is called septal fibrosis, which can, analogous to bridging necrosis, merge two portal tracts, two terminal veins, or portal tract and a terminal vein. Septal fibrosis alters hepatic microcirculation, which triggers development of liver cirrhosis. In a normal state, blood pressure in liver sinusoids is low, especially in periportal region where arterial and portal circulation merge. During septal fibrosis, new arterioles are created in the fibrous septa. They connect to original arterioles in portal tracts. This process is called arterialization of hepatic circulation. After that, new shunts start to develop between these new arterioles and terminal veins. As a result, blood flow bypasses liver parenchyma, elevates blood pressure in terminal veins, and retrogradely in liver sinusoids. The sinusoids react to this hypertension by literally cementing their walls. They close the fenestrations, and stellate cells start to produce even more collagen. Adjacent hepatocytes are shut down, and they suffer from lack of oxygen and nutrients. They start to die out and are replaced by additional fibrosis. Remaining vital hepatocytes hyperregenerate, enlarge, proliferate, and form nodules. At the end, liver structure is rearranged into multiple nodules, which is called cirrhosis. Considering the previous sentences, it is evident that cirrhosis is not a stationary disease. On the contrary, it is a dynamic progressive process, aggravating over time. Grossly, cirrhotic liver is firm and nodular. It can be enlarged, reduced, or normal-sized. Microscopically, liver parenchyma consists of multiple nodules, separated by fibrous septa. Ductal reaction and mild chronic inflammation in the septa is a common finding. Hepatocytes are irregular and often dystrophic, showing steatosis or cholestasis. Sometimes more regressive changes or even hepatocyte necrosis can be seen. In the stage of cirrhosis, it is often impossible to identify the initial diagnosis with a proper clinical context, because cirrhosis represents a uniform end-stage picture of many liver diseases. Last but not least, it is important to stress that cirrhosis develops as a consequence of long-lasting insult affecting the liver diffusely. Single-shot insult will be healed by a scar, not by cirrhosis.